Hello, friends. So I'll be talking on this topic, which was a debate in one of the mycology conference in Hyderabad on 30th September 2023. So I was debating on this topic against an ID physician. So the topic that was given to me was to debate on liposomal amphotericin B is better than azoles in treating febrile neutropenia and sepsis and fungal infections. So I had to argue for this. So the way I would look at it is, I wouldn't call this a debate. So rather, the topic that I would be covering is to gain consensus as to where we believe that amphotericin B is superior to azole. So I think that's what we would possibly agree on at the end. So the topics that I would cover is just an overview on the available antifungal agents and very briefly on the mechanism of action of antifungal drugs, bit on the background, and mainly I'll talk on mold infections where the role of amphotericin B is fairly conclusive. So we'll talk about the risk factors in mold infections and the role of liposomal amphotericin B in aspergillus. So it's just pictorially I put the way aspergillus looks and empirical and preemptive therapy in febrile neutropenia and the role of liposomal amphotericin B and role of liposomal amphotericin B in the ICU, which is important for all our intensivists, and whether there's a role of liposomal amphotericin B in candidemia. So candida looks something like that, and liposomal amphotericin B in mucormycosis, which I'm sure every listener would agree that there is a definitive role there. So these are the five subdivisions where I will dissect out the role of liposomal amphotericin B and talk about summary. So when we look at antifungal agents, they can be broadly categorized into three groups: azoles, polyenes, and echinocandins. So just to very briefly run through the azoles that are available, fluconazole, we give at a dose of 12 mg per kg followed by 400 mg per day. Day one, we give 800 mg followed by 400 mg per day. Voriconazole is touted to be superior to fluconazole, has a lower MIC and increased effect on certain candida on which fluconazole is not effective, like it's effective against brucei. Now we have a new kid on the block, which is posaconazole. Now we have isavuconazole also. And the key thing is posaconazole available both as oral and IV. It's used as prophylaxis for graft versus host disease, post stem cell transplant, hematological malignancies. IV posaconazole, I'm sure during COVID mucormycosis, even this had some role to play. So IV posaconazole is available. Then polyenes, mainly amphotericin B. So the dosage is 0.5 to 1 milligram per kg per day. We know amphotericin B has more of nephrotoxic effect. So that's why the newer available amphotericin, like liposomal amphotericin B, is more commonly used. So other thing about amphotericin, it has no effect on Candida lusitanae. So liposomal amphotericin is what we will try to talk about more because of its renal safety. And the dosage is 3 to 5 milligram per kg. When we talk about higher dose liposomal, we go up to 10 milligram per kg. Then there are amphotericin B lipid complex and amphotericin B colloid dispersion. So we'll stick to liposomal amphotericin B as the main sort of a discussion point. Echinocandins, we have three echinocandins. Most of you would have heard caspofungin 50 milligram once a day is given, and idulafungin 100 mg once a day, and micafungin 100 mg. So these are some of the sort of broad antifungal agents that are currently available. So when we look at mechanism of actions, most of these antifungal agents work around principle of preventing the fungal cell wall synthesis. Uh, so when you look at, so this is a fungal sort of a cell wall picture where you have beta 1,3 glucan and the azoles mainly act on ergosterol by inhibiting cytokine P450, which is responsible for synthesis of this cell wall. And polyenes, which is amphotericin B, binds to the sterols and leads to the lysis of the fungal cell wall. Then you have echinocandins, which act on beta 1,3 glycan and inhibits the synthesis of. By inhibiting this enzyme, it prevents the disrupts the cell wall and prevents the formation of the cell wall. So this is in brief about the mechanism of action. The azoles are on ergosterol, polyenes bind to sterol and cause the cell lysis, echinocandins bind to beta-1,3 glucan synthase, which is needed for the synthesis of this cell wall. So this is in brief about the overview on mechanism of action. So just talking about Candida. So when we talk about Candida, there are two major sort of a clinical presentation. One is candidemia in ICU, bloodstream infection with Candida or invasive candidiasis. And this is most common. 80% of the fungal infections that we encounter, maybe in ICU or in clinical situation, will be by Candida. Following Candida, the rest of the other 20% of the fungal infections are caused by invasive molds. In invasive molds, the common ones we encounter is Aspergillus or fusarium. So these are the commoner ones we encounter. And then you have in invasive molds, mucorales also. Mucorales is you have mucormycosis and rhizopus. So these are the commoner ones. And 20% of the non-candida is caused by these main molds, Aspergillus and mucorales. So Aspergillus, fusarium, or rhizopus, or mucormycosis. So there are whole lot of new emerging fungi. So emergomyces is one. So I've already covered this in one of the video. Please go back and have a look. Histoplasma is an emerging fungi. Fusarium is a plant fungi, again belonging to Aspergillosis sort of a group, and that also is emerging new fungi. And Candida auris has led to few outbreaks. So we would talk. So in these 20% of these cases, azoles are not effective. So our whole argument would be in this space of 20% where predominantly it is the mold infections, except in Aspergillus where voriconazole is the first line of choice. In all other emerging new fungi, azoles are pretty much ineffective, and amphotericin B is the main drug of choice for all these newer emerging like histoplasma, emergomyces, fusarium, so on and so forth. For Candida auris, the first line of drug would be echinocandins, followed by amphotericin B because azoles are ineffective. So we'll talk about it in little detail. So in the previous video, and I think multiple times we have spoken about risk factors for Candida, but here we'll talk about what are the risk factors for mold infections. And when we look at these risk factors, you could reconcile that most of our ICU patients have one of these risk factors, and they are at a risk of developing mold infection. So the common risk factors are anyone with a neutropenia more than 10 days. When we say neutropenia, where your neutrophil count is less than 500 per millimeter cube, they are at a risk. Or neutropenia following leukemia remission and induction, or neutropenia following allogenic hematopoietic stem cell transplant. All these are risk factors for mold. When I say mold, you're talking about rhizopus, mucormycosis, aspergillosis, or fusarium. And HIV patients who are not on treatment are a risk for mold infections or end-stage organ dysfunction. This we see in ICU, liver disease, someone coming with DKA, because DKA are at a risk for developing mucormycosis, or end-stage lung diseases like COPD, ARDS, or cystic fibrosis. They are all at a risk for developing aspergillus. We know that. And I will show you some data how ARDS also are at a higher risk of developing aspergillosis. We'll show you some data. And someone who have chronic granulomatous disease like sarcoid or who have had tuberculosis, all these are at risk for developing mold infection. And in ICU, we deal with solid organ transplant, renal transplant, liver transplant, lung transplant. All of them are at a risk for developing mold infections. Graft versus host disease, which again is a sort of ramification of immunosuppression due to hematological malignancy, so on and so forth, is a risk factor for mold. This is very important. Any patient who is on some sort of a steroid at a dose of 0.3 milligrams per kg. So zero point 0.3 milligram, if you take prednisolone, it will be around 18 mg. Who's taking steroids 18 to 20 mg per day for more than 3 weeks are at a risk of developing mold infections. Or someone who's on immunosuppressive drugs or which are uh, which are effective against T lymphocytes like calcineurin inhibitor or any of the tumor necrosis factor anti-TNF drugs for 3 months. All these constitute risk for mold infection. So I would argue that many of our ICU patients would have one of these, which will put them at a risk for mold infections. And this is something we need to bear in mind that many of our patients are at a risk of developing mold, and mold infections, azoles are useless, and we need to rely on amphotericin B, and azoles are effective. In azoles, voriconazole is the only drug you can think of for aspergillus. So now we'll talk about what is the role of liposomal amphotericin B in patients with hematological malignancies and invasive aspergillosis. If you look at all the guidelines, so the key guidelines in mycology come from IDSA or ESC mid, or this is European Conference of Infections in Leukemia. So the guidelines have come from this. We know there's no debate on that. In invasive aspergillosis, the first line drug or the first drug of choice for aspergillosis is voriconazole. So we give that. So azoles are a mainstay or isavuconazole. So voriconazole is the first drug. And IDSA puts more emphasis on voriconazole than isavuconazole as a choice of drug for invasive aspergillosis. But the question is, what if they are azole resistant? Because of overusage of azole, so many of the aspergillus can be azole resistant, and azole resistance has been reported in these studies that have come from Dutch. And liposomal amphotericin B becomes a second alternative when there is azole resistance. And this was a study where they have looked at where azole resistance is prevailing. The study came, it's a landmark study which came from the CFEM study mycoses group from the Italy, where they looked at 45 patients with azole resistance, where they had to combine echinocandins with voriconazole or echinocandins with liposomal amphotericin B or liposomal amphotericin B with voriconazole, and they found no difference. So, which means to say liposomal amphotericin B has a role to play because of increasing azole resistance in aspergillus, and liposomal amphotericin becomes an important drug in the armamentarium as a second alternative. And the response rate with the combination was up to 73%. So it goes on to show that it has a role even in aspergillus where voriconazole is the first drug of choice. And in this particular study, CFM, the mortality was 17% and response rate was 73% with the combination. So now we'll move to what is the role of amphotericin B in empirical and preemptive therapy in febrile neutropenia. So empirical and preemptive therapy with febrile neutropenia. So when we call empirical, so we need to understand what is the difference between empiric and preemptive. Empiric is where an individual who is at a risk of developing fungal infections has persistent or recurrent fever. Then you think of starting antifungals. Preemptive is where there are certain indicators or signals to say there is possibly fungal infections, either by clinical examination, with imaging, and with galactomannan being positive. If any of these indicators signal towards fungal infections, we call it as preemptive therapy. So this was a study that came from France, where they used liposomal amphotericin B as an empiric and preemptive therapy for febrile neutropenia. And you can see the 14-day survival with empiric was as good as 97.3, and even with preemptive, it's 95.1%. It was non-inferior using preemptive also. Obviously, proven infection was always, it will be more in preemptive because you have taken imaging, you have done galactomannan, and you have taken clinical indicators. Then this is another study that has come from Germany in allogenic hematopoietic stem cell transplant, empiric and preemptive therapy with amphotericin B. 100-day survival was found to be 57% and 37% in empiric and preemptive. It was higher in preemptive, and that was statistically. So this goes on to show in febrile neutropenia, even empirically starting liposomal amphotericin or preemptively starting had a good response rates. So it goes on to show it has a role. So, are there any studies whether head-to-head comparison between amphotericin B and voriconazole and caspofungin? Because the point we're debating is only azoles, not caspofungin. So, there was one open-label non-inferior trial that was conducted, and this came out in NEJM. They tried to compare liposomal amphotericin B versus caspofungin versus voriconazole. They found no difference between liposomal amphotericin B and echinocandins, caspofungin. But when they tried to include voriconazole, it did not meet protocol-defined criteria. And even now, I don't think there is a regulatory approval for the use of voriconazole as a drug of choice in febrile neutropenia. In febrile neutropenia, the first drug of choice is echinocandins, followed by liposomal amphotericin B as a second alternative, and you saw the studies. So this came in NEJM where they compared azole, voriconazole was compared with liposomal amphotericin B for empiric antifungal therapy with neutropenia. Quite a big study, 837 patients, 415 in voriconazole, 422 in liposomal. If you see success rate, there is a trend towards higher success rate in liposomal amphotericin, but it did not attain statistical significance. So liposomal amphotericin is non-inferior to voriconazole, but voriconazole is not included as a drug of choice for febrile neutropenia as a preemptive or empiric by any of the guidelines. So it is the echinocandins followed by your liposomal amphotericin B. Okay, so now we'll talk about role of liposomal amphotericin in the ICU. In ICU, what are the type of infections that we treat? The treatment of invasive, predominantly these fungal infections, the index of suspicion is in hematological patients, solid organ tumors, or in transplant patients who are on immunosuppressive. So these are the cohort of patients where we would consider fungal infections where there is a propensity to consider starting preemptive or empirical therapy. So even it is shown that immunocompetent patients also there is increased risk of invasive fungal infections, and it's come from these two studies from Belgium and UK. There are increasing risk of ICU patients developing fungal even in immunocompetent because of indiscriminate usage of antibiotics and so on and so forth. And patients with diabetes are at a risk of fungal infections, and we have seen that during COVID, who are on steroid, 23 to 36% of the diabetics are at a risk of developing the fungal infections. And diabetics with diabetic foot or diabetic ulcers are at a higher risk of developing mold infections, especially mucormycosis can be at a higher risk for these patients. And this manifests with rhinoorbital involvement with lung manifestations. So we need to be have higher sensitivity in recognizing that these patients, the simple diabetic patients with diabetic foot who are non-compliant, whose sugars are not in control, are at a risk of developing molds, and we have seen this during COVID. So what this slide basically tells is intensivists needs to be having that heightened sensitivity that ICU patients are at a risk of developing molds. Why I'm talking about molds is because molds are are the cohort of patients where only amphotericin B works and azoles cannot work. Azoles only work in aspergillus where oriconazole is the first drug of choice. So that's the point I'm wishing to make. And if it is mucormycosis, we know the treatment of choice is surgical debridement, and the only antifungal that works is liposomal amphotericin. Of course, now it is posaconazole also, which is coming, and isavuconazole also is claimed to be, but the drug of choice as per the guidelines is liposomal amphotericin B, and you have to obviously treat the underlying conditions, which is DKA or any other condition. But here, the point we are making to make is in mucormycosis, there is a debate whether we should use 5 milligram or higher dose liposomal. So higher dose is what is recommended. So now we'll talk about Candida. In Candida, we know in a sick febrile neutropenia with candidemia, the first drug of choice we all know is echinocandins. And there is no role for azoles, but there are three specific sort of a dimensions in candidemia where amphotericin B has a role. If you are dealing with intra-abdominal candidiasis due to bowel perforation or whether anastomotic leak or necrotizing pancreatitis, where there is previous exposure to azoles, where they're already exposed to azoles, obviously the first choice would be your echinocandins, and liposomal amphotericin B remains the second choice, where there has been a previous exposure to azole. Always in candemia, first choice would be echinocandins, followed by liposomal amphotericin can be a good second alternative. So this is one area where amphotericin B has a role to play. This is an important area for intensivists, which I would want them to pay attention. In patients who have a CVC line or who has an indwelling vascular catheter, and then they develop candidemia, and you are not able to remove the catheter because of difficult IV access. So there is a biofilm formation, and liposomal amphotericin B is the first choice if you have to retain that catheter. If you remove the catheter, you can use echinocandins. But if you have to retain the catheter because it may be febrile neutropenia, where finding an IV access may be difficult, or they may not be in a condition to replace the catheter, liposomal amphotericin B is the first choice because it has a biofilm penetration. Second choice is the anidulafungin, and that's the reference. It's a US study, which is a reference for this. So this is another distinct sort of a subset of patients where amphotericin B becomes the first drug of choice. And septic shock, and there, so where you have done sort of a good source control and where treatment is initiated, antifungal therapy is initiated less than 24 hours. Even then, the case fatality rate where they are in septic shock due to candidemia can be high up to 52.8%. And if they're not treated with good source control, the mortality can go up to 97.6%, and 30-day mortality is found to be 54%. So, and another, so the third distinct area is if there is septic shock and you are suspecting candida, and if there is outbreak of candida auris, then none of your azoles work. So obviously the drug of choice will be echinocandins because Candida auris has resistance to fluconazole. 100% of the drug Candida auris is resistant to fluconazole. So you cannot use azoles. So amphotericin B, 25% are resistant to amphotericin. Echinocandins is the drug of choice if it is Candida auris. If you are not able to use echinocandins, you have to consider liposomal amphotericin as the second choice. And Candida auris shows resistance to one of these three drugs, and 70% of them shows resistance to at least one of these drugs, and 25% shows resistance to at least two of these drugs, and 1% shows resistance to all these three drugs. So that is the, so Candida auris is a dreaded. So again in Candida auris, echinocandins is the first choice, and amphotericin B remains the second choice. So azoles has no role in Candida. So these are the three subgroups in Candida. So one is intra-abdominal infections with septic shock with the previous exposure to azoles, or a CRBSI, where you are unable to remove catheter and biofilm penetration is needed. Amphotericin B becomes the first choice. Or septic shock, where there is a risk of Candida auris, the coverage has to be echinocandins followed by amphotericin B as a second alternative. So now we'll move to aspergillus. So these are aspergillus. So even in immunocompetent patients, aspergillus is found to be present in 1%. And this is the study from Spain, where autopsy study where they've shown that it can be present in 1%. In ARDS, this is what is important, is a French study which showed in ARDS, 8.3% of the patients had aspergillus, and then autopsy showed 15% of them had aspergillus. So this is important for intense ways that we are dealing with ARDS who become secondarily worse with worsening infiltrate. Aspergillus has to be kept in mind. And this was a study from UK which showed even in ICU patients who develop ventilator-associated pneumonia, 12.4% of them had aspergillus. So this was a retrospective study from the Dutch Belgium mycoses study group, where they showed influenza pneumonia, 19% of them had aspergillus, and 5% of the CAP patients, community-acquired pneumonia, had aspergillus. And this was a study from Dutch, where it showed in COVID-19 patients, 3 to 30% of them had aspergillus. So what does guidelines say? Voriconazole is the first choice, so the credit has to go to Azole. But liposomal amphotericin B becomes the second line, and it is the drug of choice if the MIC level for voriconazole is more than 2 milligrams per liter. So which means there is an evolving resistance to azoles because of overusage of azoles. And one has to check the MIC. If MIC is more than 2, then voriconazole may not be the first drug of choice. It has to be liposomal amphotericin B. So even in aspergillus, where voriconazole is first drug of choice, but if one has to consider doing MIC, if MIC levels are more, liposomal amphotericin B becomes the drug of choice. And mucormycosis, we have gone through, and we know for sure that liposomal is the drug of choice, but the whole consensus is should we use high dose? So this was a study that came from France, where they used high dose liposomal amphotericin B for 40 patients for 1 month with mucormycosis, and they found a good response of 45%, and survival at 12 weeks was 62%, but 40% of them had a risk of AKI, even with using liposomal amphotericin B at a higher dose. So what about combination antifungal? Whether single liposomal is enough for mucor or it has to be combination. So these are the studies. So this study came from US, where they did combination of amphotericin B and echinocandin compared to amphotericin B with echinocandin between two sort of a periods, where increasing number of patients had combination in the 2004 to 11. There was 90 days survival, no difference. But this study from US, which came later on, where they used amphotericin B monotherapy and they compared with amphotericin B with echinocandins. 6-week mortality, there was no difference, which again emphasizes that singular agent, amphotericin B, as a monotherapy may be good enough for invasive at a higher dose. And this was another smaller study, which again came from US, 21 patients where they used monotherapy. And here they used amphotericin B with echinocandins, and successful outcome appeared similar. As you see, all patients here improved as compared to 14 in 31 patients. So that's about the combination. So pretty much we can decipher that amphotericin B at a higher dose as a monotherapy is good enough rather than combination. So now coming to conclusion, summing up in whatever we have discussed so far. So the take-home message is if someone has severe septic shock due to intra-abdominal infections with candidemia, due to bowel perforation, or due to anastomotic leak, and they have had a previous exposure to azoles, echinocandins is the first choice, and liposomal amphotericin B is a good second alternative. And this is important area in ICU. If someone has an indwelling vascular catheter and we are not able to change it due to difficult IV access and so on and so forth, and if you want to have a biofilm penetration, liposomal amphotericin B is the first drug of choice, endorsed by the guidelines by ESC MID, and anidula fungin is the second drug of choice. And febrile neutropenia, IDSA obviously considers echinocandins is the first drug of choice, and liposomal amphotericin B is a good second alternative in febrile neutropenia. And we saw the data for that in preemptive and empirical. There was a good success rate. And as per Gillis, all the guidelines ESC made and IDSA, everything suggests voriconazole is the first drug of choice. But if there is emerging azole resistance, if MIC is more than 2, then the best second alternative is liposomal amphotericin if MIC is more than 2 milligram per liter. Mucormycosis, there's no debate. So all the guidelines, so this is mycosis study group, um, education and research consortium, and this is another guidelines for European Confederation of Mycology group. So all guidelines are equivocal that the high dose liposomal amphotericin B is the first drug of choice for mucormycosis, and isavuconazole and posaconazole becomes the second choice. So this would be the take home. And what about, so my conclusion would be 20% of the fungal infections in ICU, and we saw most of our ICU patients have one or two risk factors for molds, including someone with ARDS, VAP, and all the emerging new fungi which we have discussed in the previous video, emergomyces, histoplasma, fusarium, which are all emerging. Azoles are ineffective, and 20% of the fungal load in ICU constitutes these mucorales, which can be fusarium, which can be mucormycosis, or which can be rhizopus, where your azoles are ineffective and amphotericin B is the way to go. So that would be my conclusions. So this is pretty much a consensus. So whatever my opponent argues, there wouldn't be a strong rebuttal, rather convergence and agreement as to where we see a distinctive role of amphotericin B in this select group of fungal infections. So I request all my listeners to submit their valuable work to this Journal of Acute Care, which we bring out every 3 months. So I urge all our listeners to present their valuable work and publish it in this journal. Visit my website www.drpradeeprangappa.com to rehear to this. So thank you one and all.